Assalamu alaikum. Good evening. So let us do some video. Dr. Kanit. You can see the video. I think it is visible.
Yes, madam.
Continue.
Ma'am, can I start?
Want to start? Okay.
In this video, I am seeing a child, boy, and in the hospital setting, he's not dysmorphic, no distress, or with glass, and there is some ECG probe, EEG probe in his forehead, and no other device here.
Okay.
And there is a steering loop of the baby, and there is no abnormal movement or just a steering loop.
Okay. So what do you think? What it could be?
Ma'am, I think it's a case of absence seizure.
Not a case of. Okay. So it can be absence seizure and.
Ma'am, differentially, I thought about it's a case of it is a daydreaming or
Okay. Then what history you want to take?
Okay, I want to take the history about the onset course when it and the how and the duration of the disease and what make it worse and what provoked this condition. Okay. And what make it better, and if there is any response with calling the baby, and is this is the this occurring previously or in the home or other than home or school or other site, and any family history of this condition, and any effect on his daily activities, and any effect in his performance in school.
Okay, so what examination you want to do?
Okay, I want to do the vital sign, airway, breathing, and circulation, and Glasgow Coma scale, and want to do the full neurological examination and other cranial nerve examination, and also assess the developmental status, and IQ assessment, yes, and vision and hearing.
Okay, so what investigation you want to do?
I want to do the full blood count, and want to do the EEG, electroencephalogram, in sleep and awake state.
Okay, so is it diagnostic? Which one is
Madam,
diagnostic and how long?
the EEG is diagnostic, and in ma'am, I'm sorry that here this video EEG also shown. There is a 3 spike
That
wave.
you have to say. That you have to say.
EEG wave is seen.
Okay.
The 3 spike wave.
So what management option could be?
Madam, we want to give the specific treatment of absence seizure, that is the lamotrigine and lamotrigine, ethosuximide, and or ethosuximide or sodium valproate, and want to consult with the consultant and involve the neurologist and developmental therapist, and want to involve the epilepsy nurse and contact with the school.
I understand, but here lamotrigine will be come first or other medication? You want to keep lamotrigine first?
Ethosuximide.
What are you asking me?
I forget it.
Okay, so this child, whenever you want to give your diagnosis, and then what advice you give to the parents regarding safety issue?
There is some safety issue in the home and also outside the home. In home, the parents should be aware about a safe place of the fire and the sharp objects and micro ovens and fire object in the home, and also asked to use the bathroom or during the shower time without the lock, and he's not allowed for swimming or unattended swimming, and
if the child when wants to do like driving license DLA, so what it could be?
Ma'am, if the child need the driving license, then we at least sure about that the child is free from this type of seizure for at least 2 years.
For both day and night?
No, ma'am. For daytime it is 1 year, and for night time it is 3 years.
Okay, very nice. So anything more? Okay, so thank you for your contribution. So today we see a seizure child, which is diagnosis is very right. So it is absence seizure. So you rightly say that child is it looks like not dysmorphic, appropriate for the growth. For the age, growth is appropriate. You have to plot them on the chart, and the child having one glass and some device like EEG is ongoing. So maybe child in the hospital settings, and child was doing after some time, the child having stare movement, like child was started to staring, you see, after some time. And then again, regain his like vacant look. And you see, then after some time, regain and again started. So after then, a EEG was meant there. And actually, if they give you EEG, then you'll very confident that 3 Hz per spike. So the child is having diagnosis of absence seizure. So if you say that it is absence seizure, must be. If you say the other seizure, you have to say why not. So you say that it can. It is very unlikely, as there is a very definite EEG features. So I'm not thinking of the daydreaming, but for absence seizure, daydreaming could be. And daydreaming, I can differentiate with the history and examination. Then also whether the child having the same type of movement and stare, this one in the home or outside. So I will take this history, and I can't differentiate. So you see that I'm not just saying that it is daydreaming. And another differential diagnosis could be complex partial seizure or focal seizure with impaired awareness. So it can be complex partial seizure, but less likely as the child having typical EEG findings. So your history was appropriate, something missing. Otherwise, mostly you cover. So onset, frequency, duration, how it is started, any aura is there, triggering factor. Is it resolved by stimulation? Is there any loss of consciousness, any loss of body tone, any forward drooping of the head? Why? Because, it can be, there is atonic seizure, different kinds of seizure, lip smacking, so I want to take a detailed history of the seizure, how it started and how it is progressing, and the seizure house aborted. So, and also you say that occur in the school and at the home similarly or not, any stress is the child exposed to in the school or outside, then I have to take this history, as well as I have to take the history of any hospitalization previously, any history of head trauma, or any medication is there. That is also important. Child can have previously some diagnosis that you can say, and having any prematurity, birth asphyxia, known disease, any headache, blurring of vision, vomiting, always whenever convulsion, ask about the any increased intracranial pressure related thing, any fever, ICP, and meningitis you have to exclude. Then, of course, you can't forget about family history of seizure disorder, developmental history, if it is up to 5 years, otherwise IQ history, and school history, how the school studies ongoing, and the like academic activities, any learning problem is there or not. So you understand that it is family, school history is very important. Family histories of seizure disorder is very important, and too much important. Now, for the physical examination, is there any dysmorphic features, any child vitals, and then I will check the cranial nerves and the neurological examination, but also I will check the any neurocutaneous marker is there. It is common for all the convulsion, dysmorphic cranial nerves, neurocutaneous marker. These are the applicable for all kinds of seizure. Then what about what you can do for this specific absence seizure? So I can here, although it is showing that the child having with some common child having steering and loss of awareness, but I can do also at the bedside, I will ask the patient to blow in the balloon and to do the hyperventilation. So what you heard, that was for initially, that is for the initially how it is happen, and after then you have to say that what the child having whenever the child having bedside testing, how can do, you have to explain it, okay, if it is absence seizure. Then you can go for the investigations, that is EEG. Already it shows that tree has a spike wave that can be confirmatory, but if indicated, then I will go for the MRI of the brain and video EEG. So if you are confident that you can answer these questions, then only you will say, otherwise no. So when the MRI of the brain is indicated, then it is said in the pediatric guideline, right? When it is indicated. So complex partial seizure, focal neurological deficit, any syndrome, in that time, or if there is like a status, sometimes absence seizure then is converted into status epilepticus. So in that time, I will do. If any confusion for the absence seizure, not for this video, you will say not for this video, I will do the video EEG. Video EEG also important whenever there is any confusion, like the child having mom is not confident and school teacher is complaining. In that time, if you have strong suspicion, you can ask for the video EEG even. Then go for the, but it's here clinical diagnosis is very suggestive, but you have to do the EEG must. So management is multidisciplinary team. Here I have to involve the neurologist and to start optimum anticonvulsant. So the optimum anticonvulsant is first line could be ethosuximide, then other medication is there like lamotrigine and valproic acid. So you are not defined, but ethosuximide is considered as the first line medication. Okay, first line medication is the ethosuximide. So when you can consider sodium valproate and when not, that can be a question. You know that for the female childbearing age, it is never considered as a second line drug, first line drug. And even lamotrigine, levetiracetam, both can be used first line options if other options is not suitable. And then what can be prognosis? Dr. Kanij, are you here? Tell me, what can be the prognosis? Do you know about it?
Yes, ma'am. With time, the absence seizure, if the proper medication is given, it will in control, but not resolve like the childhood myoclonic epilepsy or benign epilepsy.
So you have to say the very specific things that most children with absence seizure outgrow of them by adolescence. So most outgrow of this or can having seizure-free life by adolescence. So with appropriate treatment, seizure usually well controlled. But you know, some percentage can have like it can like transformed into the generalized tonic-clonic seizure as well. And academic support is very important because if it is frequently happen can affect learning. You have to remember this point. And yes. So, yeah, then what is your advice, or I mean, how can you prevent seizure and other things? Actually, this is more discussion will be with the communication scenario, but I'm just telling you that you said everything was very appropriate, that if any seizure happen, then you have to take the advice to the mom with a broad heading. Like first of all, you will discuss about the seizure nature and the importance of regularity of the medication and the provocating factors, sometimes stress, sometimes flickering of light can affect the seizure. So have to avoid the provocating factor. And then you will discuss about the safety measures. So what I said, first we will discuss about the provocating factors and also the seizure natural history of this seizure, and you will elaborately discuss about it. And then you will say that what safety measures. So in the home and outside. In the home, any risky things have to be covered and avoided, especially it is bathing can be like showering. Showering can be like we did ঝর্ণা ছেড়ে আমরা যে গোসল করি, it's okay, but not in the bath, and should not be closed the door inside. or when the child is in the toilet or bath time, then can be used something like outside a signal so that others can understand. And any sharp things, any things that can be like burnout have to be take the precautions. And outside the home in that times, always be ready. For example, if the child having wants to swimming, it should be supervised. If child climbing, should be supervised. uh, when the child cycling, then can do the cycling, but I mean have to be aware of the risk and should take the helmet. And then you will say the epilepsy action plan. If seizure happen, then what measures have to be taken, that would be explained to the family, to the school nurse have to be aware of the safety measures. Okay, so the like asthma action plan, there is epilepsy action plan. So these are very, very important things that I will say again and again and again, and you will also try to like the things repeatedly because these are very important. Um, Another things also, for example, if the child is looks like 13, 14, 15, then allowance, sorry, a driving license, you have to say, because 15 years, some childs apply for the driving. So driving license that you said exactly, night seizure 2 year free and day seizure 1 year free. If then they can allow to give driving license. But this child should avoid alcohol. That is the lifestyle modification is very important for them. And they can keep bracelet if they have recurrent status, although it is not applicable here. So these are our absence seizure related things. Anything, any concern for the absence seizure? Then we'll proceed for the next. Anything you want to say?
Uh, in this video, the baby have the mouth breathing. Is it a part of convulsion, seizure,
No,
or
actually
anything
no.
else?
No. Mouth breathing, like looks like mouth breathing, but it's actually hyperventilation. Like see, the child is doing hyperventilation. Maybe child was asked to do the hyperventilation. So it is usually provoked by the hyperventilation. Okay, that is you can do like in the in your chamber, but in the EEG when suspected, in that time also it was asked by this way to do the hyperventilation. Okay. One thing is hyperventilation, another is photic stimulation. It is not for the photic stimulation. I mean, absence seizure is not by the photic stimulation, but by the hyperventilation. Okay, so okay, so I think Afsanapo today will do.
Yes.
Okay, so this is your video. So actually this video is something like you have to think that first in the home, and then it shows the child was taken into the hospital, and the they want to indicate that the seizure is continuing by this way. 2 places. on করে দিচ্ছে। Okay, I think you can start, or you can take further 1 minute by your own, but video is enough to see.
Okay.
You want to start? Okay, explain.
I saw a one-year baby well in right lateral position where she is blinking of the eyelid and steering low and fisting of her upper limb, fisting of his wrist, and there is abnormal movement on the right lower limb, and there is salivation is also present. Patient is non-dysmorphic, age is growth is seems to be age appropriate. So my provisional diagnosis is most generalized tonic closing seizure is occur here. Most probably it is status epilepticus.
Okay, so if you got this kinds of, seizure in the ear, so what do you want to think that what can be some differentials?
My differential diagnosis is a case of meningitis.
Again, please. Sorry, I could not hear you.
Meningitis.
Uh-huh.
Other abnormal movements such as patient having the epileptic seizure.
Okay, so there could be some causes of epileptic status epilepticus, and some could be non-epileptic.
Yes.
Okay. Among them, infection, you said. Okay, so what history you want to take?
I will take the history of onset, course and duration of this convulsion. Is it happening first time or it is recurrent? Or what happened just before this convulsion or after that? And is he lost of his consciousness or not? Is there any relation of any apnea? Is there history of any taking of any fit or choking attack or not? History. I will also take the history of fever, and any skin lesion or sore throat infection, or history. I will also want to take a prenatal, natal, and postnatal history, and also the family history for same type of illness.
Okay. So, in the emergency room, how you want to manage?
I will immediately manage her by maintain her airway breathing circulation. As far as I can do our random blood sugar and check random blood sugar, and I want to obtain her IV access. If I can't open the IV access, I will and also give the high flow of oxygen. If I can't access her IV canal, then I will give the bacalmidazolam. And if IV access is available, then I will go through the IV lorazepam. And I wait for her convulsion. And in the meantime, I also check her saturation, her Glasgow Coma scale, and I will call my senior for further help.
Okay, so any examination you want to do for this child?
At that time, I also want to do her neurological examination, her respiratory system, and cardiac examination.
Okay. So So what treatment you will give in this acute setting?
I will acute setting as
Child
if
is
the
already got 2 doses of metajolam in the ambulance.
okay.
It's no hypoglycemia.
Then I gave them the lorazepam. I will give up to two shot of lorazepam. In the meantime, if the convulsion is not controlled, then I call my senior for further anticonvulsant drugs such as phenytoin or phenobarbital. If that not controlled, then I also take help of anesthesiologist for take to in PICU for intubation and doing the further treatment.
Excellent. So, okay. Now, I think it is now 5:50 minutes. So I just wants to discuss something here, very important, because this video is very, very important. And it's easy to understand because generalized tonic-clonic convulsion is well known, and you get the point that it was continuing more than 5 minutes. If more than 5 minutes, any convulsion, generalized or ungeneralized, even loss of consciousness in between is not there. So you have to take as a more than 5 minutes as a status epilepticus. So here what we see a child who is like can be 3, 4, whatever. So girl with you have to say the child is in critically ill or child is convulsing and the child consciousness. I mean, you have to comment on the consciousness, what you see. So the altered level of consciousness is there. Child was, if it is shows that some videos that I actually I could not show these things because it was with the like with the statement as well that what is happening. So, but some videos are there like for the status epilepticus where the child was continuously asking, but child was not responding to verbal commands. So if it is there, then you have to comment. So consciousness, responding verbal command or not, that you have to mention. And you said appropriately that child is well grown, there is no apparent dysmorphic features. In the home setting or hospital setting, if it is there, then you have to say, and child having abnormal eye, uprolling of the eyeball, as well as there was clenching of the face, and child was having both upper limb and lower limb also involvement. A child having not even at the end of the video, I see the child was continuously convulsive, child having not not gain his consciousness. So my diagnosis is child is a status epilepticus or non-status epilepticus. So if it is said, then you have to remember that always we see that this kinds of video, we become preoccupied that it can be only the epilepsy, but it can be by the other than epilepsy as well. For example, already you said that it is CNS infection like meningitis. Also, you can say it can be due to metabolic cause like hypoglycemia, or it can be hyponatremia as well as from the electrolyte imbalance. Also, it can be as a part of vascular event like infarcts or bleed, or it can be due to injury, like head injury, or also it can be space occupying lesion. So trauma, tumor, vascular, that also be here, as well as metabolic and electrolyte imbalance. If you see that in the video there is a VP shunt, you have to also mention that child can have blocked VP shunt, infection of the VP shunt, hypoxemia, ischemia also, but never forget poisoning as well. So it's like a broad heading. Okay, it is not, we are not think of only the status or in meningitis, we will take all the things. So after then, you know, I mean, outside the, I was not that much aware, but I come to know many of our colleagues know that how to take history of the seizure history. Here you have to know the very well-known things, onset, course, duration, how it is happened, how many times, is it first time or not, previously any documentation that having any seizure before. That is very common, and precipitating factors and relieving factors if it is recurrent, that you said. But another things is there which is known as ample. So ample mean that any
Allergy.
hmm,
Allergy, any medical
hmm,
history,
hmm,
past medical history such as hypoxic ischemic encephalopathy,
hmm,
shunt,
hmm,
when he take his last meal, and even
and
surrounding the injury.
yes, so this is very important. So allergy,
Allergy,
and or it can include rash as well, and medication, M, and P for past medical history.
past
So
medical.
past, we say that epilepsy, shunt, any surgery, any trauma happened, it's also past. But you can take it simply like previous any trauma, any surgery happened, that is also hypoglycemia. I mean, your differential diagnosis, whenever you see that the video is showing a status, you will just write your differential diagnosis and all the questions related to you have to exclude, right? Then you will say the fever also, and the child activity, any unusual consciousness behavior abnormality also there or not, that you will ask. So very important, these things to be asked. Overall, you can remember by this way or not, it's up to you. So after then, if you go for the examination, so examination is here, of course, if they ask you like without examination or without history, even in this type of settings, you can ask like what management you want to take, because it's emergency settings. Some emergency videos can be there that cannot be produced, like it's emergency case, and also like acute exacerbation of bronchial asthma is emergency. So emergency scenario is very, very favorable topic. So like if they ask you management, even, then you will say that I will, as it is an emergency situation, I will take focus history and examination. So focus history and examination. So the detailed history, it's not, not always possible, right? So focus history means you will do the you will look for the vitals, that means pulse, blood pressure, respiratory rate, oxygen saturation, consciousness, and you will do a overall general examination. Here you will check the neck rigidity. So actually, in the examination time, they always not ask the differential diagnosis first, because first they wants to know your approach. But if you don't know your differential diagnosis, you can't take everything in the history and examination. So I will suggest that take the differential diagnosis at least whenever you are seeing videos, usually 3 minutes, you will get 1 minute. So at least write differential diagnosis during the history whenever you are describing your history. Look at the like your differential diagnosis and then use. But it's not possible to write everything, so it can help you. And even examination is like this. Okay, so here very important: neck rigidity, overall skin survey for meningococcal septicemia, some unusual purpuric rash even can be there. So you will do rapidly here airway breathing circulation, neck rigidity, as well as overall skin survey, general examination, and you will check the pupil as well. So because pupil can there is high intracranial pressure, it takes 1 second, but it's not 1 second, at least 40 to 60 second time is required if you are very ready, but it's very important because of poisoning. Okay, and then you will say, then if I got time, then I will go for details other systemic examination. They will not further ask you anything about it, like what systemic examination. So you will say that I will rather than, when I get appropriate time after stabilization of my patient, I will do the detailed systemic examination. So focus examination and then other things. Now, okay, so what things, if then you will do some bedside test. So the bedside test, you will say that blood sugar, I will do repeatedly the blood sugar and send blood for emergency investigation like CBC, CRP, electrolytes, calcium, magnesium. Then I will go for the management of the patient. So I send you, that was like, how you manage a child of status epilepticus. So that was 2018 Evelina London. But after then there was another update, that is the APLS, when the APLS was there. So in that time, I mean, if you just open that I shared with you just today, so you will understand that there is a huge changes, and it's now very important. Not huge changes, the things are same, but just have to be here follow up with these settings. So here, remember, if the child is already got 2 doses of midazolam, you can't give another lorazepam, because benzodiazepine group you can give 2 benzodiazepine group. So if the child got 1 dose of midazolam, you can give another lorazepam. And then you will say that I will ensure if I will rapidly open the vascular channel, and then I will infuse lorazepam if the child is not got the maximum doses of benzodiazepine group of drug. Okay, and then I will start to monitor. I will keep the child in the recovery position. So you said the child is left lateral, right lateral. It's actually recovery position. You see, the child is typically posted in the recovery position. It is the position where we should keep the child if the child having any status epilepticus. So if you see a child status epilepticus, what's your role? To remove any accessory jewelries, anything around the neck, and the child, keep the child in the like flat space, and in the recovery, like left lateral position, knee bend, and keep it one side, and the hand should be one hand in the back of the neck, back of the head also, or you can keep the child hand in one side, so that there is no chance of aspiration, and it's the recovery position. So after then you started to monitor the child 1, 2, 3, 4, 5. So you started to monitor, and after if you see that child's seizure is not, I mean, if it is in your home setting even, so you see the child seizure is not controlled within the 5 minutes, then you can give midazolam, and 2 doses of midazolam you can give. But after, when seizure started, you have to take the child in recovery position, keep the child in safe, countdown start, and call 999. And then if seizure is, and after 5 minutes, if seizure not controlled, you give midazolam, and then also you will wait for the ambulance to come. If it is not controlled, even in the ambulance, if it's happened, that can be given after 5 minutes of first dose of midazolam, you can give second dose. But usually it's no, ambulance should be there. But after second dose of benzodiazepine group of drug, if seizure is not controlled, then the second line of drug is levetiracetam. So we'll check it like before it was, after like midazolam, we can give like phenobarbital, which is appropriate. But now it is said that go for the levetiracetam. Levetiracetam can be used for every situation. But if it is levetiracetam infusion is completed, it's only 10 minutes, seizure is not controlled continuously, then you have to go for rapid sequence induction. Means you have to give the anesthesia. You have to keep your team ready for the rapid sequence induction. And you can, in the meantime, you can give the phenytoin if child already on phenobarbital, or you can give phenobarbital if the child already on phenytoin. It is depends on the previous drug history. Then if it is continuously there after infusion finished, but seizure is not controlled, then you have to inform PICU, pediatric retrieval team. That means it will be, an alarm will be there, then rapid sequence induction will become. Okay, rapid sequence induction will be given. By which rapid sequence induction? It is ketamine, thiampental, propofol. So that is the things. Okay, so you see it is very nicely here explained. That is the advanced pediatric life support algorithm, which is now used. So that's the management way. But after then, what is the treatment? I mean, if it is like a patient who having continuous these kinds of seizure and having previous also history, so what advice you will give for the child? That's another things. And another things, if any seizure happen, how you manage? By the same way. Okay, that I already discussed. So hospital management, home management, two different way. But here, just these things you have to remember. I will give everything by written. I'm doing these things because everything is my, handwritten notes. So it takes some time. Okay. Okay, so then the question can be like, what is the pediatric guideline? Like, what is the indication of the MRI of the brain if you get focal epilepsy, except Ronaldi seizure? Also one of the things, but I'm just not wants to again utter that these things you can read out. Okay, so indication of the MRI, other investigations, what is written there, which metabolic panel, also these things. So any child, when you want to refer the child, remember that very important to, at last, any child management is done already. So you have to think of, you have to say management option like red flag. What red flag they have to be alert when they have to be come to the hospital. That is the alarming sign. So one is red flag. Okay. And then alarming sign, and also the action plan. Also very important. These three things I always look for: red flag, alarming sign. When have to become the same things, but action plan if any emergency happen. So it should be very much well known. I think we have to think over this. Questions could be like this also, like if the child having this kinds of conversion and you are thinking of meningitis, do you want to go for the lumbar puncture? So it should not be until a child regain consciousness appropriately. Okay, as the child is not having full consciousness, so lumbar puncture should not be started. Yes. So I think pediatric guideline will come very soon. I posted neonatal guideline in the group. So any questions?
Morsheda, in pediatric guideline, I think there is no levetiracetam, right? But we will say now it is. When we asked our, then we now we management of this. We should tell them if they
Yes,
asked us.
because it is now very much well established and
Okay.
like
Okay.
2 to 3 years, and it will come in a recent. Like you see that pediatric neonatal guideline, they give it up to 28. 25 to 28, 3 years. So even if you feel that if you feel that here, whenever you are saying that levetiracetam, if you confidently say, no problem. Confidence approach is very important. So if they ask you levetiracetam, so you can say that according to the APLS guideline. And I think it is now, I mean, I'm very much confident that in each and every trust they are using this APLS guideline, because anyone in UK, they have to do the resuscitation counselor arranged APLS, APLS kinds of, like all the pediatrician working there, they by their own cost, they send the doctor for the APLS training. So it's now they're using. So I think you can use it. Very important. For all kinds of seizure, if you see, yes, Dr. Shajia. So all kinds of seizure, one is levetiracetam. Even levetiracetam is using for non-seizure cause also. I mean, it's now, it is very favorable item. Okay. So then who will do? I think Nadira is remaining to do. And Rifat, you did? Forgot. Nadira, are you ready?
হ্যাঁ আপু
করনি last দিন, right?
না লাস্টে করি নাই
কঠিন একটা জিনিস দিলে তুমি কি খুব অখুশি হবে?
অখুশি হব না, বলতে পারবো না এইটুকুই।
No. It's not like this. So you will try to understand, okay? And you make your diagnosis, no problem. But so everyone will contribute. So everyone will write. I am describing a child who is who having seizure at the age of 6 months, and that time the seizure was a mixed kind of seizure. So forward movement, backward movement, and yes, forward and backward kinds of movements at the age of 6 months, and that time there was developmental delay as well. And now the child is presented with these kinds of seizure. The child having child is already on 2 anti-epileptic drugs, but the seizure is not controlled. And actually in the real exam, it was like this, the child having the seizure was really, the video was confusing because many of our candidates, because that year I forgot, but I have a good friend, so with whom I read, Pakistani girl who's now working in the UK. So we are very good friend, and she was excellent. So after this video, she was so depressed because she also got 0 of this video because everyone was confused on this video. So the video was something I tried to synthesize, that the background history is like this, and this having different types of convulsion. Okay. Also remember that in the videos, child having some scar mark in the face. Okay, some scar mark in the head also it was showing. Some injury mark in the front of the face and the side of the head as well. Side of the head and front of the face. Now you see the seizure.
I don't believe it. What's wrong now? My man's forgot I've got football tonight.
And?
Nothing. It doesn't matter.
So you say, oh, I don't believe it. And then nothing.
Don't be so nosy.
You asked you to join in. Mum's forgot my kit again.
Come on, lads. Get a move on.
So I've got no kit.
It's all right. There'll be something in the cupboard you can use.
You can wear those like shorts again, then.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he going to be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay? Me and Andy are just going to sit here for 5 minutes. You okay? Yeah? You'll be fine.
So again,
What's wrong now?
My mum's forgot I've got football tonight.
And?
Nothing. You just don't be so nosy.
You asked you to join in.
The cupboard you can use. Andy, you okay? Yeah?
So is he going to be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay? Me and Andy are just going to sit here for 5 minutes. You okay? Yeah? You'll be fine.
okay, so another settings, same child. So just imagine that the same child with these kinds of movement. Two different movement, okay? Same child doing these two types of movement. So send me the and what's your thinking? So two different movement is there. And background history,
The school setting boy, he lost sudden control and tends to fall. And in other setting, hospital setting, there is a device attached and there is myoclonic jerks.
Okay. So the background is this kinds of seizure disorder, and now the child having, you said myoclonic jerk and loss of tone, and child tends to be fall down, and child in the face having multiple cut marks. Anything more you see the child having? What happened in the child head? What is, you did not mention it.
In the school setting, child is wearing a head protection device. Helmet.
Yes. And child having loss of, oh, you said everything. Okay. So very nice. So please tell me that what's your thinking? What it could be? Only one of our colleagues makes the appropriate diagnosis. I will tell the name, but before that, get your others. Afsana, are you here? You're right. So the diagnosis, whatever, but you took the appropriate clinical findings. That is, can be enough. So can you tell me anything like what kinds of, if it is happened repeatedly, what kinds of movement it is?
Which one?
Both one. It is the same child having these things and previously child having this problem. So at least you can say that this is a complex seizure and could be syndromic or not syndromic. So syndromic is not like child having facial dysmorphism only. Syndromic, West syndrome, right? West syndrome having special kinds of seizure. So they're not having any facial dysmorphism, but they are syndromic seizure, right? So it is a complex seizure because when they have different kinds of seizure, already child on two antiepileptic drugs, still child having convulsive, having these kinds of movement, so it is definitely complex seizure. Okay, so if you say these things enough. And but brilliantly, Dr. Shadia first said that it is a Lennox-Gastaut syndrome. Yes, definitely, you are very right. And also Dr. Afsana said it is Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome is the diagnosis because, you know, infantile spasm can be converted into Lennox-Gastaut syndrome. They have relationship. Okay. So Lennox-Gastaut is already only said when they have seizure, they have more than one type of, they have seizure onset at the childhood age, they have one type of seizure, they have characteristics, EEG abnormalities, they have delayed developmental milestone, although it is not shows that the child having delayed developmental. I'm unable to show this. Okay, so so Lennox-Gastaut syndrome, but the question will definitely not around the Lennox-Gastaut syndrome. Only the things we will look for that I will ask you now. Okay. So if you see these kinds of seizure, or if you think that it is any abnormal movement, you can say that child having some abnormal movement. So, but it's not coriform movement, because you know sometimes coriform movement is different, like rhythmic movements. They are doing changing their hands, body, dystonia. You know, dystonias. The things of coriform movement, so they are totally different things. So now, if you say that if it is a complex seizure and having can be syndromic, non-syndromic, and in the background, if you see that the child having long-term this problem to epileptic, so what history you want to take for this child?
For this child, I want to take history of the onset, course, and duration. And is there any particular thing that aggravate or relieve the condition? And for this, how long he is taking the treatment, and about the compliance of the drug treatment. And,
very good.
Any
Yes.
any history of aura or anything happened after the convulsion? Any other abnormal movement or abnormal behavior or history of feet? Any vision or hearing problem? Any feature of neurocutaneous syndrome? And any family history of family history?
Exactly. Yes. So other than
birth history.
What other things? Birth history. Okay. So what other things? Something important remaining. So the child in the school. So what is important here? Child school is important.
Academic and school environment history.
And is there any problem there? School knows about the epilepsy action plan. That is also school nurse is aware of it. So that is also important. And social history is important. Any stress around, any disability living allowance, and child is already on any epilepsy group or not, parents is aware of it, is there I mean any chronic kinds of illness, they are aware of the family. Okay, so that we'll remember. And regarding the whenever you know, history is important everywhere, here also important. So that this child is already in some medication, the doses of medication, when the dose last change, although that may be not elaborately, no scope to ask in the history video station when it's related to the video station. But I mean, your memory should be like this, that you will say these things. For example, child treatment history, I will take the detailed treatment history, the medication the child is already going on, is there any compliance problem, then how many medication is already given, and when the medication last change, any effects of the medication child is getting. So after that, also the what test already done, any EEG findings, specific things is there, and any MRI of the brain already done or not. So these are the things also very important. Any surgery happened. So and a child is multiple type trauma. So I mean, which kinds of treatment child got for the trauma, and what preventive measures the child got already. So the home modification is very important. Any home modification already given or not. So everything is around me. So until my examiner stop me, I will say continuously, no one stop me, because I know many things. Or you have to understand that you cannot proceed more than 1.5 minutes for the history, because you have to say many things on the examination as well. So tell me about the examination.
I want to see the vitals, airway, breathing, circulation, and detailed neurological examination, including cranial nerve, and also do the developmental assessment, and also see the general condition of the skin to find any signs of neurocutaneous syndrome.
Okay. So then any test you want to do?
EEG.
And any other test is important for the renal test out or this kinds of seizure? Nadira, any other test is important? It's mentioned in the pediatric guideline. What's the indication of MRI of the brain? Can you please tell me what's the indication?
MRI of the brain, if there is focal epilepsy, intractable seizure. Intractable seizure is the indication of MRI of brain. So there is role of MRI of brain.
Anything more? Only intractable?
Intractable seizure, focal epilepsy, epilepsy with focal neurological sign, any associated neurological deficit, and if patient develop epilepsy below age of 2 years, loss of previously good controlled seizure, infantile spasm.
So, you know, it is like you have to say these things must. If you see that any child who having very difficult seizure, you would say that I will do the MRI of the brain. So some indication is there. So then you will say what's the indication. Okay, so then the next question is all the things related to that, like what you will do, next, like this. Which carrier they cannot take? Those who have seizure disorder. They should not take any like Air Force or Army, these kinds of I mean, these kinds of, those who have the seizure which is long time seizure, they should not take. So if it's like seizure happen and it's controlled, then it's okay. One thing I forgot to say that whenever we are saying the different kinds of seizure, although it is, I mean, febrile seizure will control within 5 minutes usually, but you can say that I have to exclude the complex febrile seizure as well. So when the child is within 5 years. Yeah. So, and also the contraception is another thing. So, if the child is having contraception issues and other things, then you will send the child to the appropriate, appropriate contraceptive advice, because some anti-epileptic drugs and contraception can be there. So, you have to say to the, if adolescent child and epilepsy they shows, then advice, among the advice, everything that I said before, you have to say, and you will add contraception. So, I mean, you have to see these things and you have to memorize and you try to verbalize. So, how much you prepare yourself? I mean, now you can read out, but memorization, verbalization can be done also. The letter, like before exam, you can, but the preparation is to what you have to say, you should know. Okay, that is the preparation time. But before exam, it is like you have to verbalize that I will say this, this. And you can do it repeatedly and you can even hear your own voice and prepare yourself. So the first seizure was atonic seizure. So loss of tone, sudden loss of tone. They have prone to have a trauma to the head and face trauma. You see the child is having atonic
I don't
seizure.
believe it.
You okay? In the gym, okay? Being on you. You okay? Yeah. You'll be fine. Minutes. You two go on, join Miss Macon in the gym, okay? Me and Andy are just going to sit here for 5 minutes. You okay? Yeah. You'll be fine.
Why is this? Yeah.
Andy?
The atonic seizure.
Andy?
Okay.
Yep.
And another seizure, it was a myoclonic component is there. There is another seizure here. Myoclonic component is there. So here myoclonic component is there. Again, if you see this seizure, okay, so after then we have another two more. No, not two more. I think we have to do another 3 to 4 videos. Okay. So anyone here wants to do like Rifa, you did not practice? The last day, Luna, Dr. Sajia, and Luna, Sajia. I forgot. So I want to make sure that everyone is practiced. So I write it. Fatima. Rifat, you did not do. So remaining one things. Are you free? Rifat. Okay, Dr. Afsana. So you will do one. Okay, so you will do one.
Last one now or last one?
হ্যাঁ তুমি কল আসছে
না না না
কি বললা
না বললাম এখনই করবো নাকি আরো করবে?
না 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 তুমি এখনই করো কারণ আমাদের এখনই করো আরো কিছু বাকি আছে আরো একটা দিন লাগবে বাট ইটস নট বি সানডে it will be Monday. We will do the clinic neurological examination and then overall all neurology video will recap and do everything. I mean, what is remaining. So I think Nupur will not do these things. Nupur is busy, so remaining is Rifat can do. Nishad is not responding that much, so the remaining is okay. So I'm just giving a scenario.
Girl presents to me with a gait problem. When I ask the girl to walk, she walks like this.
So can you hear actually what is here? Anything is audible?
Audible.
Audible, no? Okay, so I have to
notice the gait.
No, I have to stop. Okay.
ভালো মতো দেখতে পাচ্ছি।
Child came from the Pakistan and the child having yes, so no medical documents with the child and child gait is like this.
আপু অনেক ফাস্ট যাচ্ছে কি তাই কি এরকম ভিডিওটা এরকম এবং অনেক মোটা মোটা শর্ট শর্ট লাগতেছে নাকি আমার এখানে?
আচ্ছা এটা আমি একটু ছোট করে দেখতে পারি একটু মোটা মোটা লাগতেছে আমার কাছে কিন্তু চাই নো আসলে হ্যাঁ আরেকটু করে দেখাবে দেখো আর কি লাগবে মানে ক্লোজলি ভিডিওটা করা হয়েছে আচ্ছা ওকে একটু শর্ট করে দিব দিয়ে দেখবো কেমন হয় দেখো তো এখন কি বোঝা যায় মোটা মোটা তো না ভিডিওটা একটু কেমন যেন মনে হয় যেন উপর থেকে নিয়েছে আর কি Okay, tell me. After then we'll start video of like I think we'll do the dermatology video. I mean videos mainly dermatology, respiratory and neurology. And some neonatal video also there.
দেখতেছি তাও তো
Okay,
ফুড
start.
ড্রপ
Start. Afsa.
বুঝতেই পারতেছি না আপু দেখি I can see a girl very short very obese and walking with support of adult person and there is I think dragging of the both mainly right foot during walking due to foot drop most probably.
So
আমরা ভিডিওটা ভালো বুঝতেছি না
okay, so you for example if you don't understand the any gait, so the child is showing the gait, right? And if you say that the child having no like whenever you are seeing a gait video and it's not understandable, so at least you understand the child muscle. You understand?
I think very obese maybe due to hypertrophy of the calf muscle also the buttock also heavy.
Okay, so I think the
I think
videos is not appropriately shown here. So it's shown like child is obese. Child is not obese.
but there is waddling gait and hypertrophy of the calf hypertrophy and also drooping I think foot droop foot
Okay,
droop.
so if it is the waddling gait, what's your differential diagnosis? So also Dr. Afsana first said that it's waddling gait. So if it is waddling gait, then what's your differential diagnosis? It is bilateral.
Differential diagnosis it may be a case of DMD maybe spinomuscular atrophy rickets also other myopathy like peripheral neuropathy also spina bifida
Okay, so
waddling gait.
so tell me that you are thinking of it is a DMD for a female child.
No, DMD first no diagnosis.
What could be the
Spina rickets
spinomuscular?
also spina bifida, but in case type 3 spinomuscular atrophy type 3, but I have to assess if there is any Gower sign or not, and then dermatomyositis may also have myopathy. Rickets, but there is no feature of rickets, I think.
Okay, so you know when there is a bilateral waddling type of gait, the child is
It's developmental dysplasia of hip also.
yeah. So here you know bilateral waddling type of gait if there, then always think by this way: neuromuscular disorder, skeletal problem, okay, or orthopedic condition, neurological condition, or any other things. So here I want to say you one thing. It's like if you see, I mean, this many of like Many of us, we make these things. Like, if we cannot understand which kinds of gait, then it's waddling gait. I mean, it's not written anywhere. It's like we are saying that because, it is not hemiplegia. It's quite understandable. It is not diplegia, right? Child is walking smoothly. If it is not any, what other gaits is remaining when there is no hemiplegia, diplegia, quadriplegia? Then could be myopathic, right? Or waddling gait. Waddling gait known as myopathic gait as well. So you will think of it could be muscle disorder. Here can't put Duchenne or Becker. It's not the age. So spinal muscular atrophy, congenital myopathy can be, and skeletal problem. If you think, then developmental dysplasia of the hip, and also like what can be peripheral neuropathy. If they are, then also they can have this problem. So if you make your diagnosis like DDH, so the examiner is saying that the child is diagnosed as DDH. So what history you want to take for the DDH? Developmental dysplasia of the hip.
Onset, course, duration, and of the problem, and details developmental history, and any history of associated both upper or lower limb involved or only lower limb involved, and there is any associated any skin problem or skin rash associated with any abnormal movement. Then during whole perinatal history, like antenatal history, birth history, and postnatal history. There is any less fetal movement or after delivery. What about the screening text of what about the screening test of developmental dysplasia of the lower autonomy at 6 weeks and at birth, and any measure taken for that, any investigation done at that time, any family history of similar type of illness, any history of
you said, okay, very good. Family history is first. If family history for
family
history is there, and is there any oligohydramnios, few food abnormalities? So we know if family history, firstborn, female, few bone, few fluid, face up, okay, and any food abnormalities before, any multiple pregnancy, other siblings, twin, part of the twin, that is also important. Even the child require any molding during the delivery, also important. So new
delivery,
the process of delivery. So the things is here the risk factors. You will mention the risk factors. Okay, Barlow test is all done or not. So we will check up for this. So familial can be so important, very important. Familial position of the foot. Okay, so after then tell me that what examination you can do for this child. Although this child is shown by this way, but something is missing that you will see in your examination. So tell me what examination you will do.
I will do the Gower sign and any asymmetry of the buttock muscle, and also examination of the joint movement, and then to exclude the differential diagnosis, I will do examination of the other system like skin survey, musculoskeletal examination, neurological examination also. And
so what is the name? Unequal leg. What test you will do?
Shortening of the Gallagher test or
Gallagher sign. Gallagher sign you will do. Unequal leg. So unequal
of the
knee.
leg length discrepancy. Yes.
So unequal leg. So important things. There is so many videos I showed, right?
In case of a Galaji test, usually unilateral development. If bilateral, in that case,
Then it
is it
can,
positive or
yes.
not?
No. It can be absent or positive. You cannot predict, because I mean, if it is like one leg is shortening one way, another leg another way. So Galaji sign means, yeah, these 2 foot should be in one way, but it is not. Then the Galaji sign is positive, right? I mean, when the child is knee flex. So when there is a leg length discrepancy, then it would be Galaji. But whenever it is bilateral DDH, then can be like leg length discrepancy can be absent.
Okay.
So now what treatment you can give for this child?
I will involve at first. I will do the investigation to confirm the diagnosis. Ultrasonogram of the hip joints, and also if needed,
Hip joint for this child, 4 years.
X-ray of the hip joint. Also, ultrasonogram may be needed. Sometimes
No.
may be needed.
Ultrasound usually not done for the DDH at
Oh,
this age.
ultrasound in neonatal is.
So if it is given the child is neonatal age, or you can give it up to the 6 months of age. If you give, I mean, it's not usually given more than 6 weeks, but it can be given. I mean, it depends on the first epiphyseal center is developed usually 6 months and onward. First epiphyseal center. So X-ray will check the epiphyseal center is developed or not. That's your aim. But if you are not seeing this, then you have to be. It is usually said that ultrasound is advised up to 6 weeks. Okay. Then sorry.
Okay.
Okay. Then you will what you will give.
So X-ray of the hip joint, but sometimes if any difficulty in diagnosis may need MRI.
Yes, very right. Okay, after then what
and
treatment?
After then I involve the orthopedic surgeon for open or close correction of this problem.
Yes. So usually at this age, pelvic harness having no role. Usually. But it is pelvic harness is the treatment for the initially. It is under 6 months of old. That times you will give the plaster type of things. So pelvic harness, it is said you have to keep the child 24 hours up to 7 days a week until you require the child to change the bath, change for the cleaning. So they will keep the harness and then it will make a correct shape. So you will keep the child in a abducted position. Okay. But if it is not improved, then you have to give the child. So you have to give the child open and closed surgery. It's depend on the orthopedist, not my task. So DDH is very important. Please go through the DDH related things. Many DDH related patient leaflets and many things is there. So you have to go through these things. So I mean, you have something you have to read out, right? So everyone, you will read out the things I shared with you. If it is very old, then you can't. I shared with something, but double nappies is now not accepted. It's like old things. Okay, so I think now then we'll go for the neurological examination next. So you will try to revise, some London School of Pediatrics Neurology videos is there. So London School of Pediatrics YouTube, if you go through, then you will get it. Okay, and then you will see so that you can understand that there is some difference, the traditional way of neurological examination and the examination of, what we do for the MRCPCH. So you'll check that. Thank you, everyone. Anything you want to say, please.